Hi, everyone. My name is Vijayaraghavan, and today I'm going to talk about multifaceted approaches to address tobacco use among populations experiencing homelessness. What we'll do today is describe the precipitants and drivers of homelessness, describe the epidemiology of tobacco use behaviors among people experiencing homelessness, discuss tobacco-related inequities, causes of tobacco-related inequities, culturally relevant tobacco use screening and intervention considerations among people experiencing homelessness, and share additional resources. So about me, my name is Maya Vijayaraghavan. I'm an associate professor of medicine at the University of California, San Francisco. I'm a primary care physician at the Zuckerberg San Francisco General Hospital. My research program focuses on tobacco use behaviors among people experiencing homelessness. I'm particularly interested in the intersection of tobacco use with mental illness and substance use. And I'm also interested in developing cross-cutting community-based and health systems interventions to increase access to cessation services in community-based settings, reduce tobacco use and tobacco-related disparities among people experiencing homelessness, and also evaluate the impact of tobacco control policies on vulnerable populations. So who do we talk about when we talk about homeless populations in the US? So the federal definition of homelessness includes individuals and families who lack a fixed, regular, and adequate nighttime residence. These are individuals and families who are at risk of homelessness in the next 14 days. They may also include unaccompanied youth or families with children who are unstably housed, individuals and families fleeing intimate partner violence or other types of violence. Homelessness is increasing. As you can see here, in 2020, 580,000 people were homeless on any given day. This is only slightly less than what it was in 2007, where 647,000 people had experienced homelessness on any given day. As you can see, homelessness has been rising in the past few years, and particularly exacerbated during the COVID-19 pandemic. Unsheltered homelessness has increased by 30%. You can see in this figure from the National Alliance to End Homelessness that among people who are homeless, the proportion who are unsheltered homeless is actually quite high. Among individuals experiencing homelessness, it's almost a half. Among those who are chronically homeless, it's pretty much most of the population. You can also see among veterans and unaccompanied youth that unsheltered homelessness is increasing as opposed to sheltered homelessness. Racial ethnic minorities are overrepresented in populations experiencing homelessness. Even though white populations comprise the majority of people experiencing homelessness nationally, there are some racial ethnic groups that are overrepresented among populations experiencing homelessness, including Black, Hispanic, Latino populations, those who self-identify as being multiracial or Native American. These populations are overrepresented, and minoritized populations are more likely to experience homelessness because of lack of employment, poverty, less access to healthcare, and higher rates of incarceration. So I like to think of homelessness including drivers and precipitants. And drivers of homelessness are inadequate housing or inadequate access to affordable housing, high cost of living and low minimum wages, structural racism and discrimination in access to housing and opportunities in communities, unemployment, and lack of a safety net. Whereas precipitants of homelessness may be mental health or substance use disorders. With this parallel epidemic of homelessness, we also have a parallel epidemic of tobacco use among people experiencing homelessness. This is a figure from a report that was done by the Public Health Law Center, which I highly recommend that you take a look at if you haven't had a chance, and describes the epidemiology of tobacco use in the context of tobacco use among people experiencing homelessness. So we know that across studies in the US, the prevalence of tobacco use among people experiencing homelessness is consistently between 60 to 80% compared to 13 to 14%, which is what it is nationally. Homelessness is an independent risk factor for tobacco use. We know that smoking rates among those with mental illness is at least double that of those without, and mental illness is common among people experiencing homelessness. And we also know that many people have had shared experiences with the criminal system, and those shared experiences also increase risk for tobacco use. There's a higher prevalence of tobacco use among sexual and gender minority groups that are also overrepresented among people experiencing homelessness. So what is the epidemiology of tobacco use among people experiencing homelessness? What we know across different studies is that most initiate smoking before the age of 16. The average daily cigarette consumption is 10 to 16 cigarettes per day. And we know that over a third report smoking within 30 minutes of waking. And these two markers of daily consumption and time to first cigarette after waking are metrics of nicotine dependence that we can ask all of our patients or clients when we encounter them in clinical or community settings. We also know that many engage in high-risk smoking practices, including sharing cigarettes and picking up discarded cigarette butts. So in addition to initiating early participating in high-risk smoking practices, there's also high rates of concurrent tobacco product use. Over 50% of people who use cigarettes who report also experiencing homelessness use other forms of tobacco. And in a recent study, we found that 58% of men and 45% of women report using other forms of tobacco in addition to cigarettes. The products that are the most common include roll your own tobacco, cigars and little cigars, and e-cigarettes. The motivations for use are lower cost of some of these products, particularly little cigars. Some people use these products to actually quit cigarette use. Some people report that the novelty of these products and the flavors are appealing, and there's just a general curiosity about them, and that motivates the initial use and continuous use. And in a study that we did a few years ago, we found that fruit-flavored products were the most common. So who are more likely to concurrently use tobacco products among people experiencing homeless? So epidemiological studies have shown that people who use multiple tobacco products tend to be younger. They also tend to be male. They smoke more cigarettes per day. They have higher stress levels. They have higher levels of substance use. They also report more homelessness episodes and unsheltered homelessness. And interestingly, they have a higher perceived risk of smoking-related illness. So there does seem to be some cognitive dissonance because they are also using multiple harmful tobacco products. And they do attempt to quit more than those who use only cigarettes. So tobacco-related inequities are really common among people experiencing homelessness, and the health impact of tobacco use is very high among people experiencing homelessness. So people experiencing homelessness are 3 to 5 times more likely to die prematurely than those who are housed. Smoking-caused illnesses are the leading preventable cause of morbidity and mortality. When you think of the 3 leading causes of death, substance use is among the leading causes of death, but tobacco use comprises half of all the substance use-related deaths. Cancers, the second leading cause of death, are also really common, particularly cancers that are related to smoking, bronchus, lung, and trachea, and cardiovascular disease, which is related to smoking. When you look at those who are less than 45 years of age, the incidence of smoking-caused conditions is 3 times higher than age-matched populations. Smoking also incurs a substantial economic toll. In a study of adults experiencing homelessness in Dallas, Texas, 55.3% reported spending more than $20 a week on cigarettes, and people who reported an income spent 31% of their yearly income on cigarettes. And among formerly homeless adults who were living in permanent supportive housing, we found that people spent between 12 and 30% of their monthly income on cigarettes, and that cigarettes and paying for cigarettes interfered with their ability to pay rent. Tobacco use is also associated with food insecurity, with higher odds of food insecurity among those who are heavy smokers. So why do we have such stark inequities among people experiencing homelessness? So we can attribute these inequities to structural factors. We know that tobacco industry targeting is quite common among some populations, particularly those who are underserved. In this particular instance, R.J. Reynolds, one of the big tobacco industries, targeted people experiencing homelessness through a campaign called Project Scum, a subculture urban marketing, recognizing their vulnerability to nicotine dependence, and they targeted these populations in certain parts of San Francisco where they tend to spend a lot of time. Other structural factors include structural racism and discrimination. We know that populations experiencing homelessness are living in racially segregated, poverty-concentrated neighborhoods with little opportunities for development. And they experience racism and discrimination, which leads to high levels of stress and tobacco use. And this systemic targeting of racial ethnic minority groups by the industry, including price promotions, sponsorships, giveaways, having high tobacco retail densities in those neighborhoods, which increases exposure to tobacco products, and marketing of flavored tobacco and menthol flavored tobacco products to certain communities, including Black African American populations, are some of the structural and systemic reasons for why there are such high rates of tobacco use among people experiencing homelessness. Other structural factors include high rates of trauma. Over 80% of people experiencing homelessness have had lifetime experiences of trauma, and many have experienced multiple traumatic experiences, including adverse childhood experiences that include physical and emotional neglect, maternal depression, divorce, mental illness, substance use. And these experiences are over a set of adverse community environments that include lack of quality housing, violence, discrimination, community disruption, and poverty. And these adverse childhood experiences can double the risk of nicotine dependence, and stress and high risk behaviors really impact development of chronic disease, and a general lack of opportunities in our communities limit structures for coping and recovery. So what are the behavioral factors that can influence tobacco use? We discuss mental illness and substance use as precipitators of homelessness. They are also highly linked with tobacco use behaviors. We've seen in our studies among people experiencing homelessness that tobacco use is linked with stress relief, treatment for anxiety. It co-occurs with substance use. It's especially common among people with PTSD, major depressive disorders, and psychotic disorders. As in this particular instance, one of our participants talks about the relationship between alcohol and tobacco. The one element, let's say, one element is like, the cigarette would be land, and then alcohol would be like the ocean, like the other element, and they go great together. So when the opiates are wearing off, a cigarette will bring the opiates back a little bit. The alcohol is a little different. The alcohol, it seems to go hand in hand. With opiates, it's more like a tool. We also know that social norms play a big role in smoking behaviors among people experiencing homelessness. A lot of the day is structured around smoking breaks and shelters and substance use recovery programs. We know that the criminal system does have smoke-free policies, and people often engage and have to go through forced quit attempts while being incarcerated, but they resume smoking after release. And that was particularly the case for this one participant in our study. I got out of prison, I wasn't smoking. But when I got out, a lot of homeless people on the street, and I was homeless too. I went to the homeless shelters and started. Everybody around there was smoking. And I didn't like the smell, but one day I was at the camp and someone gave me a pack of cigarettes, and that's how I started again. Boredom and maybe secondhand smoke dragged me again. There are organizational and system level factors that are related to tobacco use among people experiencing homelessness. So there are limited opportunities for services, limited access to cessation services in community-based sites that are serving people experiencing homelessness, and limited access to smoke-free housing. There's also a general pattern that homeless service providers do not ask about tobacco use. There's a myth that people experiencing homelessness are not interested in cessation, or that smoking cessation is not a priority when homeless. And competing priorities of finding housing and basic subsistence needs limit the bandwidth to address tobacco use. But despite these barriers, people experiencing homelessness are interested in quitting. In fact, what we found is that approximately 40 to 50% of people experiencing homelessness make a quit attempt in the past year. And this is very similar to the general population. However, most quit attempts are unassisted. And this is where there is room for improvement. Most people who attempt to quit smoking relapse to smoking. The quit ratio, which is the ratio of former smokers to ever smokers, is 9% among people experiencing homelessness, but over 60% in the general population. However, the spontaneous yearly quit rate without any treatment is 4 to 5%, which is very similar to the general population. So what these statistics highlight is that people experiencing homelessness do attempt to quit, similar to the general population, but there's an urgent need to disseminate interventions for cessation in service sites for people experiencing homelessness to increase the efficacy of quit attempts so that they can quit successfully. So what are the known factors associated with quitting and quit attempts? We know from our studies that staying in shelters or transitional housing that have smoke-free policies may increase quitting and interest in quitting and reducing smoking. We also know that quitting smoking does not interfere with other substance use, but may actually reduce the number of days abstinent from alcohol. We also have found that participating in a smoking cessation program at transitional shelters can increase quit attempts and smoking reduction. So what is guideline recommended smoking cessation treatment? So to treat tobacco use disorders, we rely on two primary approaches, and the two approaches go hand in hand. The two approaches are cognitive behavioral therapy to address the behavioral components of nicotine addiction, and pharmacotherapy to address the physiologic component of nicotine dependence. And that includes nicotine replacement therapy, or NRT. Other medications include bupropion or varenicline. You may have heard of Chantix as well. And the recommendation is that combination therapy, long-acting patch with a short-acting gum, or nicotine replacement therapy with bupropion or varenicline is the preferred approach to treating tobacco dependence. And more recently, there's some data to suggest that starting with varenicline as the first agent to treat tobacco dependence is the preferred approach. And you'll have to tailor this according to people's individual needs, but the idea is to offer counseling with pharmacotherapy to treat tobacco dependence. We also recommend at least 3 months of treatment, but people can extend it to 6 months or more if they're benefiting from it. And you can start treatment even before people are ready to quit, to prime cessation behaviors. And people can start these medications at the appropriate dosages even a month before they actually are ready to set a quit date. So how do we intervene? The biomedical framework is to recommend guideline recommended smoking cessation treatment, which is pharmacotherapy and counseling. And we offer this within the framework in our clinical settings, but we send them out to the real world where there is a lot of exposure to tobacco products, where there may be no access to smoke-free environments in short-term housing or in tent cities or encampments or homeless shelters. So in order to address tobacco use among people experiencing homelessness, we think we need to think about multi-level interventions. And I like to use the social ecological model to think about the context of tobacco use and how to intervene among people experiencing homelessness. So at the policy level, we have clean indoor air laws, cigarette taxes, and regulation of new tobacco products. At the environmental level, we have smoke-free housing and local tobacco control policies. At the organizational level, we have access to cessation care and access to healthcare. At the social level, we have social norms, media influences, mental health, and substance use. And all of these factors and domains are interacting with each other to increase self-efficacy for behavior change at the individual level. So what are some of the culturally relevant tobacco use screening and interventions to consider among people experiencing homelessness? So when we talk about tobacco screening, we use a universal approach. We need to focus on minimizing barriers to tobacco screening. And we can do this by asking about tobacco use at intake in shelters, supportive housing for formerly homeless adults, and substance use recovery programs, and offer access to cessation services. An opt-out method where everyone is asked about tobacco use and given the opportunity to decline services may be preferred to opt-in approaches where they're asked whether they want information on tobacco use. And I think given the high rates of concurrent tobacco use, it's also important to ask about use of other tobacco and nicotine products. What are other considerations? So given the high rates of trauma among people experiencing homelessness, a trauma-informed approach may also be important to consider. And this approach realizes that there is widespread impact of trauma and understands potential paths to recovery. It recognizes that the signs and symptoms of trauma in clients, families, staff, and others involved with the system. It responds by fully integrating knowledge about trauma into policies, procedures, and practices, and it resists re-traumatization of clients and staff. A trauma-informed approach may be particularly useful in counseling interventions for smoking cessation. So a few years ago, we conducted a Cochrane review, which is a compilation of all of the studies that have been conducted to date among people experiencing homelessness to address their tobacco use. And the combination of all of these studies yielded some really important findings that I will share today. So we found that there was strong support for interventions that provide guideline recommended smoking cessation care. We also found that there was higher intensity or longer interventions may be better than brief interventions. So longer duration of the intervention, so for a longer period of time, and higher intensity per visit. So longer visits than shorter visits may be potentially beneficial and more effective than short visits. We also found that interventions with support for other issues like substance use may be better than interventions that just focus on tobacco use. So, for example, combining tobacco cessation counseling with wellness-focused counseling, or counseling that's focused on substance use with mental illness and tobacco may be particularly beneficial for people experiencing homelessness. We also looked at contingency management interventions, which are interventions where they provide financial incentives to stop smoking. And we found in this Cochrane review that they were not effective in aggregate. However, these studies, there were only 3 to date when we did this review. They were limited by small sample size. Despite these methodological limitations, these studies did actually find that they had among the highest abstinence rates among people experiencing homelessness. In one particular study, they reported a rate of 40% at 4 weeks follow-up, which is comparable to the general population that's engaged in smoking cessation care. And I think this approach does hold promise as a potential treatment for people experiencing homelessness, particularly as more studies are using this approach. We will be able to look to see whether some of these estimates are changing around efficacy. We also found minimal effects on mental health and substance use, but there were few studies that had consistent metrics of these outcomes. So this is something that we need to consider as we're designing studies and developing approaches for people experiencing homelessness to have consistent metrics of mental health and substance use that we are measuring. And what we hope to do as new studies are completed is to update these findings over time. So, what are some of the gender considerations and preferences for cessation? As we heard before, we know that there is a high rate of trauma and trauma experiences among populations experiencing homelessness. So, trauma informed approaches may be particularly relevant to women experiencing homelessness who have experienced intimate partner violence. In one of our studies, we found that one on one counseling may be the preferred approach for women choosing to self-isolate as a pathway to recovery, as opposed to group counseling. In a recent study, investigators also found that male concurrent users were less likely to prefer medications for cessation than cigarette-only users. And female concurrent users were more likely to have fatalistic attitudes about their tobacco use, even if they quit smoking. Now, these insights are particularly useful when designing smoking cessation counseling interventions, as they could be taken into account to develop targeted approaches for people experiencing homelessness. So what are some of the ways that we introduce smoking cessation interventions in community-based sites? So this is an example of a pharmacy-linked intervention for smoking cessation for people experiencing homelessness. We partnered with a community-based pharmacy that couriered medications to sites, and we partnered with 3 shelters. And we trained shelter staff to provide brief cessation counseling to residents. So they asked about tobacco, and they provided brief cessation counseling using the 2A's and R model: ask, advise, and refer. But we also connected shelter residents who participated in our program to a pharmacist at our community-based pharmacy site to provide counseling and free delivery of medications for cessation for 3 months. And these are medications that were offered, that were delivered to the participant at the site. And of the 52 participants that enrolled in our first cohort of this study, 71% reported making a quit attempt and 84% reported using NRT. And we also found that using medications in the past week increased chances of making a quit attempt and reducing number of cigarettes smoked. We just completed the second iteration of this study, which is funded by the San Francisco Cancer Initiative, and we're beginning to make plans to recruit the third cohort. So we'll see over time whether the intervention is sustainable, whether it can be scalable to other sites, and also whether it consistently leads to reduction in tobacco use among people experiencing homelessness. So another study that we're doing is called a smoke-free home study, where we're working with formerly homeless adults living in permanent supportive housing. And this study is really a study focused on changing the environment around tobacco use in their homes so that it might motivate smoking cessation. And our goal is to encourage voluntary adoption of smoke-free homes, to reduce secondhand smoke exposure. And as a result of reducing secondhand smoke exposure and smoking less indoors, people have found that it may actually motivate cessation behaviors. So this is our logo. We talk about why it's important to have a smoke-free home through a counseling intervention. And then we talk about steps to make your home smoke-free and how to achieve those steps. And we follow people over time at 3 months and 6 months follow-up to see whether the intervention counseling may have motivated people to voluntarily adopt a smoke-free home and even perhaps quit smoking. So what are some of the pitfalls to avoid? So we know that most quit attempts among people experiencing homelessness are unassisted, and most people prefer quitting cold turkey. But we know that in order to increase efficacy of quit attempts, it will require targeted counseling and education on how to use medications for cessation. People report many reasons for not wanting to use medications. They're concerned about side effects. There was a general mistrust of medications. There's a concern that they have not worked in the past, so lack of efficacy. And some people can't just access those medications. So as providers, we need to regularly check on the use of medications, the dose of medications, and whether adjustments need to be made. So over the course of this work, by myself and many others in the field, we found that smoking is a financial burden, and encouraging quitting increases financial and housing stability. We know that persons experiencing homelessness are interested in quitting and benefit from guideline recommended smoking cessation care. And given the high rates of mental illness and substance use, interventions may need to be longer and more intensive. We need to offer counseling within the context of other life stressors that include trauma. We need to relieve financial burden through incentives, and we need to encourage voluntary adoption of smoke-free homes for those who are recently housed. We can achieve this through partnerships with pharmacies, shelters, and housing providers, and these partnerships may offer the opportunity to expand cessation services to community-based sites that do not have them. So I'd like to end by sharing some of these resources that you can look through. And if you have some time to do an evaluation, please do so. Thank you so much for your time.